Hi, this is Mike Kutcher. It's a great privilege to be invited to present a case for the unresolved issues in coronary intervention sessions. I'd like to thank David Reisig for his masterful leadership, along with Mark Reisman and Jim Hermuller for their time and consideration to make the SIF 2020 virtual meeting a reality. Today, I'm presenting a case of acute refractory cardiogenic shock treated with PCI and Impella. I don't have any relative financial disclosures. We did this case at Wake Forest Baptist Medical Center in Winston-Salem, North Carolina. The objectives are to present a systemic case with refractory cardiogenic shock that was not responding to intense escalating therapy, to outline a strategy for Impella support and high-risk multivessel PCI, and to report on the postoperative course and weaning of Impella support. And finally, to review current concepts on percutaneous hemodynamic support for cardiogenic shock. Our patient is a 71-year-old Middle Eastern female who presented to an outside ED with nausea, vomiting, abdominal pain, and shortness of breath that had evolved over the past 2 to 3 days. Her past medical history was significant for diabetes, hypertension, hyperlipidemia, renal insufficiency, and non-compliance with medication. She progressively became hypotensive, hypoxic, and developed pulmonary edema and poor O2 sats. She was transferred to Wake Forest Baptist Medical Center, CVICU, where she was intubated and placed on IV Levofed. The EKG revealed anterior Q waves and ST elevation 1 millimeter in leads V1 to 4 and a right bundle branch block. There was diffuse pulmonary edema on chest X-ray. The echocardiogram demonstrated severe anterolateral apical hypokinesia with an LVEF of 30 to 35%. Initial troponins were 2.45, BUN 22, creatinine of 1.49, and the serum lactate was 2.9. We suspected a late presenting anterior STEMI with early shock. The decision was made to take the patient for emergency cath, possible PCI. Access was via the right femoral artery. The following stenoses were identified: 70% ostial left main, 98% proximal LAD, 99% mid-LAD, 95% proximal circumflex, and 90% OM1. The right coronary artery had distal stenoses, but there were strong right to left collaterals to the distal left anterior descending. An intra-aortic counterpulsation balloon was inserted via the right femoral artery in hopes that the patient would be a surgical candidate. Access via the left internal jugular vein for Swan-Ganz monitoring was achieved. After her diagnostic cath, CT surgery was consulted, but felt the patient was not a candidate for bypass due to small vessel targets. Troponins started increasing to greater than 80. On one-to-one IABC, she still required increasing doses of IV dopamine in addition to IV Levofed. The LVEF was down to 20% with a cardiac index of 2.0. Ironically, the pulmonary wedge pressure was 12 to 14. In addition to progressive cardiogenic shock, possible sepsis was also considered. In view of the above, the risk-benefit ratio favored escalation of percutaneous hemodynamic support for revascularization as best possible by complex PCI. The patient was taken back to the cath lab. The IABC from the day before was via the right femoral artery. Angiography of the left femoral artery demonstrated good caliber. Left femoral artery was accessed with the micropuncture technique and escalating dilators to insert a 14 French delivery sheath. IABC was removed and right femoral access was upgraded to 8 French sheath for complex PCI. Successful Impella CP insertion via the left femoral artery was achieved utilizing standard technique. An 8 French EBU 3.5 launcher guide catheter via the right femoral artery access was used to cannulate the left coronary artery. And this was one of our working views. We first addressed the proximal left anterior descending stenosis by implantation of a 2.5 24 millimeter synergy stent. After stent implantation and high pressure dilatation, the proximal lesion was corrected, but there was evidence of some distal dissection in the mid-LAD. This was addressed by implanting a 2.5 12 millimeter synergy stent. After stent implantation and high pressure dilatation, there was excellent resolution of these stenoses. We next addressed the proximal circumflex lesion. In this setup view, we were concerned about whether there was a vessel dissection or rupture at the proximal left anterior descending stent site. But the patient was stable and we proceeded ahead with working on the circumflex. Proximal circumflex was treated with the 2.25 24 millimeter synergy stent. And after high pressure dilatation, there was excellent improvement of the proximal circumflex. We next addressed the ostial left main lesion with implantation of a 3.08 millimeter synergy stent. After stent implantation and high pressure dilatation, we did note that what we thought could have been a stent dissection or rupture in the mid-LAD was merely a diagonal coming across, but there was evidence of stent deformity of the ostial left main. To address this, we implanted an additional 3.08 millimeter Zions Alpine stent, and post-stent implantation and high pressure dilatation, the stenosis was significantly resolved, and there was no stent deformity. This is the final angiogram showing improvement of the proximal mid-LAD, proximal circumflex, and the ostial left main. After the complex PCI, the Impella CP was continued at P7 with a cardiac output of 2.8 to 3.0 liters per minute. The patient was transferred back to the CVICU for continued Swan-Ganz monitoring. The first 24 hours after PCI, the pulmonary wedge pressure was 8 to 10. The echo demonstrated good Impella position. There was an improvement in the EF to 40%. She still seemed to have a mixed picture of recovering cardiogenic shock and possible sepsis. We increased IV fluids to aim for a pulmonary wedge of 16 to 18. We reduced dopamine to renal dose, and we plan to reduce the Levophed. Broad spectrum antibiotics were continued, and we decided to continue Impella for another 24 hours. Eventually, the patient was discovered to have an E. coli UTI. Antibiotics were continued. There was no bacteremia. She was weaned off vasopressors. The Impella was removed postoperative day 3 without complications. She had resolving moderate to severe renal insufficiency. She then developed C. diff infection that was treated with another course of antibiotics. She required extensive physical rehabilitation, but eventually was discharged in stable condition after a 19-day hospital stay. The long-term course, she had repeated monthly admissions for decompensated systolic heart failure, but no MI. The LVEF consistently was in the 20 to 25% range, and she required a life vest. There were multiple other medical issues as worsening kidney function, diabetes, anemia, and urinary tract infections. She remained quite debilitated and was very sedentary. Eventually, after 3 months, she was made palliative care by the family. The patient expired 4 months after her initial presentation of cardiogenic shock. The learning points of this case, IABC was used as a bridging strategy to allow time for an aggressive heart team analysis and a comprehensive decision process. This was a good demonstration of an escalated percutaneous mechanical hemodynamic support strategy for deteriorating cardiogenic shock, SCI stage D, utilizing Impella support for complex PCI in a patient who was turned down for CABG. Although the patient subsequently had development of end-stage cardiomyopathy, she survived through initial cardiogenic shock and lived 4 months to spend time with her family. This is a recent publication by SCI on the stages of cardiogenic shock from stage A at risk, stage B beginning, stage C classic, stage D deteriorating, and stage E extremis. Classic cardiogenic shock is a patient with hypoperfusion that requires interventions such as inotropressors or percutaneous mechanical support to restore perfusion. Our patient was really in the stage D deteriorating state, where she had failure to respond to initial interventions, including intra-aortic counterpulsation balloon. For the increased hemodynamic support with these devices, there also is an increased invasive possibility of complications since the devices increase in size. Reviewing the hemodynamic comparisons between IABC and Impella, IABC increases diastolic blood pressure, decreases afterload, decreases myocardial O2 consumption, increases coronary artery perfusion, modestly enhances cardiac output, modestly improves ventricular unloading, increases mean arterial pressure, but you must have some level of LV function and electrical stability to be stable. The Impella unloads the LV and increases forward flow, reduces myocardial oxygen consumption, improves mean arterial pressure, reduces pulmonary capillary wedge pressure. The 2.5 and the CP devices provide greater increase in cardiac output than the IABC, and you need adequate RV function to provide LV preload and hemodynamic support. When we look at all these devices, the implantation of the Impella improves the cardiogenic shock outlook. I'd like to thank the Wake Forest Baptist Medical Center Cardiac Cath Lab RT and RN staff, Michael Camerata, who was the cardiology fellow that scrubbed in with me on this, and Adam Cecil, who provided excellent care and treatment in the post-Impella strategy. And special thanks to Teresa Drawn, who prepared Cine clips for this presentation. I'd like to thank you for your attention, and I'd be happy to have any questions directed to my email. Thank you for your time and consideration.